Knowing the evidence on the efficacy of medications for ADHD, that is, how well they work in randomized trials, and their effectiveness, which is how well they work in real world, is really needed to inform the discussion with the patients and their families before starting a pharmacological treatment. It is also crucial to be aware of the evidence on the safety of medications for ADHD and how their side effects can be managed. I am Samuele Cortese. I am a professor of child and adolescent psychiatry at the University of Southampton in the UK, and also honorary consultant with Solent NHS Trust in the UK. And I have been conducting research on ADHD and seeing children, adolescents, and young people with ADHD for more than 20 years. And I particularly focus on the treatment of ADHD. In this session, I will focus on the evidence on the efficacy of medications for ADHD. The second session will cover the evidence on the effectiveness and how to measure the effects of ADHD medications in clinical practice. Finally, the third session will focus on the safety and management of side effects. Let's start with efficacy. Despite the controversies around medications for ADHD, in particular psychostimulants, and the general misinformation in the lay press, it should be noted that medications for ADHD are among the most studied medications in psychiatry, and we have currently a large body of evidence on their efficacy from randomized controlled trials, spanning more than 4 decades. The results of these trials have been summarized in a meta-analysis, which is a type of study that puts together information from available trials on a specific treatment to generate a more accurate estimation of the effects of the treatment. The meta-analysis used information from 133 randomized controlled trials. 81 were in children and adolescents, 51 in adults, and 1 in both. Before I present the main results of the meta-analysis, I would like to remind an important concept, that is the concept of effect size. This is basically a number that provides us with an estimate of the size of the effect of a treatment. As you can see in this table, when this number is around 0.2, this means that the effect of the treatment, even though statistically significant, is not really impactful from a clinical point of view. When the effect size is around 0.8, this means that the treatment brings a really important, a tangible effect, not just a statistical difference. Values around 0.5 are considered medium. So coming back to the meta-analysis, let's see what it found in relation to the efficacy of ADHD medication, which is estimated by the reduction of the severity of the ADHD symptoms, inattention, hyperactivity, and impulsivity. The meta-analysis included trials on medications that are approved for ADHD in many countries, such as methylphenidate, amphetamines, including lisdexamfetamine, atomoxetine, clonidine, and guanfacine, as well as medications that are not approved for ADHD, but for which trials are available, such as, for instance, modafinil and bupropion. So this table reports the effect size with their 95% confidence intervals. The table shows that after pulling together data from a large number of trials, all medications were superior to placebo in terms of efficacy in children, because, as you can see, the effect size is higher than 0. However, not all medications are made equal. The effect size, which was the highest effect size, around 1, was for amphetamines. The lowest, but still in the medium range, was for atomoxetine, around 0.5, which is similar, for instance, to the effect size of antidepressants for depression. As you can see, methylphenidate had a quite high effect size as well. You can also see the high effect size for bupropion, but I must say that this should be taken with caution because of the large confidence interval, which tell us that the real effect basically will be much lower or even higher. I would like now to highlight that effect size around 1 are not only the highest across treatments used in psychiatry, but also among the highest across all medicine, as shown in this figure, which plots the effect size of medications in psychiatry in white and the medications used in general medicine in blue. As shown in this other table, in adults, amphetamines were still the medications with the highest effect size, even though their effect size was slightly lower than the one found in children. And methylphenidate and atomoxetine have similar efficacy. Modafinil was not better than placebo. As you can see, the confidence interval crosses the zero. So this meta-analysis also importantly provides us with information on how medications compare to each other. As shown here, in children and adolescents, amphetamines were better than methylphenidate, which in turn was better than atomoxetine, which was not significantly different from guanfacine. In adults, amphetamines were better than methylphenidate and modafinil, and methylphenidate was better than modafinil. I think it's very important now to note that these results refer to the group level. So for instance, when we say that amphetamines are better than methylphenidate, this is true on average. But for some individuals, methylphenidate or other medications may be better, maybe more efficacious than amphetamines. So evidence from meta-analysis like this one is not intended to be a prescriptive guideline. Rather, it aims to inform the shared decision-making process between the patient and the prescriber. It is also important to appreciate that the evidence that I presented so far is based on short-term randomized controlled trials, with an average duration around 12 weeks. However, of course, ADHD tends to be a chronic condition in many individuals, so clinicians generally treat them far beyond 12 weeks. So the question is now, do the positive effects of ADHD medication persist when the treatment is continued over the long term, or do they attenuate over time? Well, it's challenging to answer this question based on evidence. And indeed, to answer this question in a rigorous way, we would need kind of long-term placebo-controlled randomized trial. But of course, it's not ethical to randomize someone to placebo in the long term when there is evidence that the active treatment works well in the short term. And it's not practical also to conduct long-term randomized controlled trials. However, fortunately, there is a type of randomized controlled trial which is called withdrawal or discontinuation trial, which allow us to gain insight into the longer-term effects of medications. There have been actually a few of these trials in ADHD, and in the largest of these ones, children who had been treated with methylphenidate for an average of 4.5 years were then randomized to continue the treatment or to go to placebo. The results showed that those who stayed on methylphenidate presented better scores on the evaluation of the severity of the symptoms of ADHD compared to those who were assigned to placebo. However, the effect size was not as big as the one found in the short-term trials of methylphenidate. It was almost half compared to the one in the short term. So does this mean that over time the effect of methylphenidate decreases? Is there a kind of phenomenon of tolerance? Certainly this is a possibility, but the percentage of patients who develop tolerance is currently unclear. However, another possibility is related to the fact that when children and their families were approached to take part in the study, many parents declined, and they stated that they knew that if their children stopped medication, things would worsen. So it's possible that this study recruited mainly mild cases, and that the difference from placebo were not so evident. So to summarize, we have seen that there is a solid evidence that ADHD medications, in particular stimulants, work well, at least in the short term. It's more difficult to provide high-quality evidence on their effects in the longer term. even though it's likely that long-term effects are, at least in part, maintained over time.